Hello, everyone. I'd like to welcome you to Ethics Rounds, July 14th. We have four wonderful cases to discuss today, and the first three cases deal with determining a safe discharge for patients. So, as I said before, I want to develop an ethics framework for discussing safe discharge cases, and one could group these type of cases into three different types. One type is the patient insists on leaving when the staff believes it is not safe. And these cases that we're discussing today will typify this first type of case. But other types of safe discharge cases involves instance, the hospital says discharge is safe, the patient is willing to go, but no place will accept the patient. And then the final type of case is that the patient refuses to leave after the staff offers a safe discharge plan. And this has happened on many occasions as well. So our first case involves a 66-year-old male presented in February with 10 out of 10 back and chest pain, diagnosed as type B aortic dissection, and he underwent a repair for that. Post-op, the patient has slowly recovered from this illness. The MRI does show multiple areas of vascular watershed infarcts, probably resulting from the surgery. Concerns have been raised regarding his abilities to care for himself and his capacity to make decisions regarding his health. He scored 13 over 30 on his MoCA scale, and we'll discuss more the relevance of that. So based on his clinical presentation and the MoCA scale, a discharge to a subacute care facility is recommended, but the patient lacks insurance, and hence guardianship is filed with papers certified by two physicians that he lacks capacity. The patient remains in the hospital for several weeks while the guardian process plays out. And the patient, however, is adamant that he wants to go home. So what are the competing ethical principles in this case? One is respect for patient's autonomy. The other one is beneficence, doing good for the patient. Non-maleficence, do no harm to the patient. And then we have justice, allocation, or distributive justice, in the sense that, this patient is medically stable, but he's been in the bed for several weeks waiting for the guardianship. And discussions regarding potentially unsafe discharge should take in an account an ethical framework. However, the issue is how to balance these competing ethical principles. In this case, the issue was beneficence, doing good for the patient. And how do we balance that against patient autonomy? So as I mentioned before, there was a concern for cognitive impairment with the MoCA scale. So what exactly is the significance of a low MoCA test? Just to get everyone up to speed, I want to show you what the MoCA test consists of. It consists of visual spatial questions, naming questions, and then memory, attention, serial subtraction of 7 from 100. By the way, I once I get up to 93 for myself, I usually do poorly. Language, abstraction, delay, recall, and orientation. So the question is, so what does the cognitive impairment, cognitive impairment does cognitive impairment preclude capacity? Now, tests have shown that diminished cognitive ability is consistently correlated with impaired capacity to consent to medical decisions. However, having said that, cognitive impairment and dementia do not necessarily preclude capacity. And in one study looking at cognitive impairment in Parkinson's patients, capacity to consent to research, Parkinson's patients with cognitive impairment. However, almost 20% of these patients with impaired cognition were still capable of providing their own informed consent for a drug trial.
Dr. Silverman, sorry to interrupt you, but cognitive impairment, there is mild, moderate, and severe. I'm a psychiatrist, geriatric psychiatrist. I testify in the courts several times. The bottom line is, I agree with you, cognitive impairment is not the criteria to decide the capacity. But at the same time, the study you are mentioning, are they saying mild cognitive impairment, moderate cognitive impairment, or severe cognitive impairment? So mild cognitive impairment never correlates. And I have a problem with MoCA, even though my colleagues in consultation liaison use MoCA. Our patient population, elderly, they always score low on MoCA, even somebody who didn't even suspect cognitive impairment, severe, significant cognitive impairment. So just a point to make.
Okay, so you're saying that's not surprising in the elderly.
Mild cognitive impairment by criteria of MoCA is not surprising. Whereas,
okay, all right, good. I thank you for the comment. And I'm not surprised by your comment. So the gold standard for capacity is the MacArthur Competence Assessment Tool for treatment. And this employs a semi-structured interview-based format, and capacity to make decision encompasses 4 major domains. 1, understanding the relevant information, appreciating the situation and potential consequences, and 3, being able to manipulate the information in a rational way and then expressing a choice. So for this patient, a capacity assessment was made, and it revealed that the patient was able to understand he has an inherently higher risk for complication, readmission, and death, even death, given his lack of social sources. Upon asking the patient his perception of his risk, he stated, "I understand that there is a risk to me if I go home, but everyone who is discharged from the hospital has a risk of something bad happening." He further added, "I would rather die at home than die being held hostage in the hospital." He pointed out that, how can you tell if I am capable or not of living on my own if you never give me a chance? I think that was a fair question. So let me ask you, should the patient exercise his autonomy and be discharged to his home with the assistance of his sister who lives across the street? So let me see what you think. Yes, no, not sure. 3 more seconds. More people could vote. If you don't know the answer, just say not sure. Okay. All right, let me end the poll, share the results. So I'm thinking you're seeing the results. So a lot of people said yes, not sure, and then no. So the ethics recommendation here was, well, a difficult ethical dilemma regarding the balancing the patient's alleged needs for a guardian versus maintaining his freedom to live the life he desires. The patient demonstrates, on one hand, significant cognitive defects, but on the other hand, again, as mentioned before, the relationship between cognitive function and social functioning is not always a direct one. On multiple accounts, he is back to his baseline functioning, and capacity assessment demonstrates the patient has capacity to exercise his autonomy. And the prospect of him incurring significant harms by going home is not enough to limit his freedom and autonomy. Our recommendations was also to enhance safeguards to ensure a safe discharge, as I mentioned before, optimize what his sister could do for him. Again, the sister lives across the street, arrange for home care visits and hospital follow-ups. And planning for discharge is more than capacity evaluation. And this slide shows the list of additional safeguards that was arranged for the patient. So there could be what I like to call a safe enough discharge, maybe not optimal. And I don't think we could have an optimal safe discharge for everyone, but to have, considering the social resources available, optimize a safe enough discharge. And that was done for this patient. However, 1 week after discharge, we found out that the patient was admitted to a hospital in Pennsylvania. The sister reported the patient missing. The police was able to locate the patient via his cell phone, and the patient was picked up in Pennsylvania, standing by his car, acting confused. He was also intoxicated with alcohol. The patient was hospitalized for 8 days and then discharged to home. A week later, or 2 weeks later, he was admitted to another hospital. I'm not sure of the details of that hospitalization, and then he was discharged home again. So my question to you, was the UMMC discharge not safe, or was deference to the patient autonomy appropriate? That is the question that remains with this issue. And I like to say, you have an ethical dilemma when, after you decide on what is an appropriate action, you have a moral, what I call a moral remainder. I mean, did we do the right thing? Are we doing the
Dr.
right
Silverman,
thing?
sorry to interrupt. You want us to have a discussion, or you just want us to listen and say yes or no?
Oh, no. Well, yeah, good point.
Because there are,
Let me open it up to the group. What do you think?
yeah, I agree with your recommendation. I think UMMC did the right thing. Ethical committee recommended correctly in this particular situation. The only thing I put not sure for your question, because you only asked, we only know his ability to manipulate the information, understand the information, express his choice. But to a certain extent, I would go further and ask him what are the consequences. I would establish all the 4 points in the capacity assessment before I would have a little bit more discussion. But in the end, I agree with you. I think we made the correct decision, and I would have done the same thing. Monday morning quarterbacking is very easy. You can look back and say, well, patient ended up in the hospital, or he put himself in an unsafe situation. But in this particular case, I agree with the decision.
Okay, well, I appreciate those remarks. I will mention that a lot of staff did feel uneasy with this case because of his MoCA scale, and it was a lot of staff did feel uncomfortable, and I agree with your comments that well, you try to do what you think is the right thing, but there may be, as I said before, a moral remainder. Other thoughts?
Henry, I have a quick question. So the staff that felt uncomfortable with the decision, what was their choice? What was their options? What did they plan to do? Keep him in the hospital?
They wanted a guardian to send him to a subacute facility.
I had several patients whom we appointed guardian. They are not helpful with placement. And also, no facility will accept a patient involuntarily by force. Most of the places we send the patient, and they can walk out. They are not locked places. They can walk out. I learned it hard way after keeping the patients for 3 months, going through the guardianship, and then the guardian couldn't do anything. Most of the time, if it is appointed, either Department of Aging of the state or city, they don't do anything. They actually give us a hard time, finding this place is not good, that place is not good. But eventually, when you send them, they walk out on the same day.
That has happened on several occasions. Good point. Good point. Let me show you quickly this next case. So this next case involves a 19-year-old male with a history of poorly controlled type 1 diabetes, multiple admissions for DKA, and he was admitted after he was found unresponsive and in DKA. And this was the 8th admission for this patient for DKA this year. Hospital course, low blood sugars throughout the day, managed with snacks. He eats sporadically and is not cooperative with all the diabetes care. Patient is mostly reserved and not being conversational with the staff, and sometimes he's threatening to the staff. One night he had an outburst that required the birth team and redirection. He said, well, if I get DKA, I get DKA. Now, social situation, patient had been living with his aunt, father is deceased, and mother lives in DC, but cannot provide care for the patient. Now his aunt says she can no longer provide care for the patient, and hence we have the situation in which no family member can provide a place for the patient, and admittance to an inpatient psych unit is not indicated because he doesn't have a psychotic illness that would warrant placement in a psych unit. He was not considered a threat to others or a threat to himself. He intermittently engages with the staff, but frequently states he doesn't want to talk, and hence it was we were unable to assess his decision-making capacity initially. So what do we do now? There was some discussion about a court-appointed guardian, but we thought that, similar to what was said before, what is the court-appointed guardian going to do? The court-appointed guardian can't make this patient improve his diabetic care. So fortunately, the patient, we were able to engage in a conversation with the patient, and to make a long story short, he understood the risks and consequences of not being adherent to his diabetic care. He communicates the understanding of how to notice and treat hypoglycemia, abnormal and normal blood sugars, and how to take his insulin. When asked as to why he does not take his insulin, the patient reports he does not like being poked. So our assessment was that he understood the risk and benefits and alternatives to treatment, and patient appears to have adequate reasoning and ability to make decisions and communicate his choice. Now, even though he understands the risk, he did report that he does not think that these adverse events will happen to him. The patient says he has other family members and friends who can stay with him, but he will not clarify. So our conclusion was the patient has capacity to decide his disposition. We will work on an appropriate disposition for a safe discharge for the patient. And so the question is where to go. Actually, the only option would be discharge to a shelter with a fridge. We discussed that this could be a safe or safe enough discharge if he receives education regarding the care of his needles for insulin use, outpatient follow-up, and the knowledge that he can return if he experiences diabetic symptoms. The patient accepted to go to a shelter. He had to arrive at certain times and cannot wear tank tops or shorts and must attend a gospel ceremony. Social worker provided the patient with pants, a t-shirt, and sent a lift flex link, and the social worker will continue to follow. So what happened with this patient? Well, we found out that the patient never showed up at the shelter, and the registered nurse care coordinator called the mother, but no answer, and the patient did not show to any of his clinic appointments, even with the assistance of transport being available, and case closed with the transitional care coordinator. And the further follow-up is that a few weeks later, he was admitted to Union Memorial Hospital. He was found unresponsive at home by family, blood glucose reading high. He was last seen in his normal mental state 1 day prior to admission. No family member was present with him in the ED. Mother last spoke with her son the day before and confirmed he had been taking his insulin and following an adequate diabetic diet. Next day, DKA now resolved. They assessed his capacity, and they thought he was able to communicate a choice, understand the clinical facts, appreciate their significance, and he has rational, logical justification for accepting or declining medical care. So, and the final assessment was the patient does not represent a threat to himself or others, and patient elected to leave against medical advice. So now was the UMMC discharge for this patient not safe, or was deference to the patient's autonomy appropriate? What do you all think? I mean, these are tough cases, and as I said before, you do have this moral remainder in the sense of, are you doing the right thing? But it appears on the balancing, it seems at the time that this is the appropriate thing to do. What other thoughts from you all?
I have a thought. Can you hear me?
Yes.
Yeah, hi. Hi. So, both of these cases really have the intersection, I think, between so many social issues and ethics. I think that the ethical discharge in this case was correct, in my opinion, but this patient, although he's 19 and is of age, is extremely immature and probably does not have full frontal lobe development, and I don't think is making rational choices. But there's only so much you can do ethically. There's so many social issues here, and I don't think he really at this age can understand what it would mean to lose a limb or be on dialysis for the rest of his life. And the whole other social issue is that, I know this isn't part of an ethical rounds, but every time he's admitted, there's no insurance, or there's medical assistance. So there's just so many issues here. But I think if it's just talking about the safe discharge, what else are you going to do? I mean, this person is refusing to, or doesn't have the ability to comply at all with care he needs to provide for himself.
Right. Yeah. Well, that's the social situation is key, and it is unfortunate, obviously, but what's the alternative?
So you can't keep him against his will. I don't think. I think he says the right things, but obviously doesn't follow them. I don't know how you can force somebody to do it.
Right. Well, that's the question on the table. How do you force him to adhere to his diabetic care? And I glad you mentioned about the frontal lobe development in these young adolescents. Someone asked, is there some past trauma that the patient experienced early? Well, I
can comment on that. Number one.
Okay, good.
Just because patient disagrees with us, you cannot say he's making irrational decisions. Number two, the state to state legal situation is different. I practiced in New York 35 years. I'm practicing in Maryland for 12 years. In New York, you can make a case if somebody is not able to survive safely in the community, is dangerous to himself or other. In Maryland, they are very strict, the judges. Patient has to imminently go out and say he's going to kill himself or kill others before you can define them as dangerous to himself or others. So there are legal issues, there are social issues, and there are ethical issues. I think we don't have a choice for this patient except to agree to discharge. And frontal lobe, we can rationalize our thinking, saying why this patient is not agreeing to rational decision. For us, it is rational, but patient has his own ration. As long as he understands the situation, we have no choice.
Well, thank you for those comments, Dr. Doty. I think also the other side of the coin, if you could call it that, is that the other choice is to take away someone's autonomy, his liberty. I like to refer to live a life that he or she feels he or she wants to live. We discharge a lot of patients who are substance use disorder we send them to a shelter, but in essence, they're really living on the streets. And it's hard to reconcile the poor social situation that these patients have. Well, let me also, I'd like to ask this other question that probably will remain unanswered. In the hospital, we're always trying to develop a safe discharge, and we have these criteria. And many times, if if anybody from OT is on the call, but many times we say, well, this patient requires 24-hour supervision. And I'm just wondering if that is in this era of diversity and inclusion, whether we're being discriminatory unintentionally against patients and families with insufficient social and economic means to provide 24-hour supervision. And I think that's a potential concern. And then I like to say again, there are optimally safe discharges, and then there are safe enough discharges given what's feasible and reasonably available to patients and their families. And the final thought is determining when a discharge is or is not safe enough can benefit from an ethical framework. Now, having said that, let me go on to this third case. Is it a safe discharge for this patient? In June 2022, we have a 72-year-old male admitted from home with septic shock and contracted extremities. He has grade 4 sacral decubitus wounds and soft tissue wounds on all his extremities. Patient has been mostly bedbound and is overall not responsive, but able to have brief 1 or 2 word sentences at a time. So let me give you quickly his timeline of patients' hospitalizations during the past year. In April 2022, he was admitted for progressive cognitive impairment and fevers, had osteomyelitis with sacral decubitus ulcers. The patient was discharged with home nursing as the daughter was adamant about declining skilled nursing facility due to perceived worsening of her father's condition when he was last in rehab. He was admitted a month later for the same thing, worsening sacral decubitus ulcers. The patient appeared malnourished. There was a concern then that the patient is not safe enough to return home, and a recommendation for placing in a skilled nursing facility. And in fact, the social reported to APS his concerns, Adult Protective Services, his concerns about potential neglect. However, the patient was discharged to home with home nursing for wound care. Patient admitted in July for the same thing. Recommended placement to skilled nursing facility. Patient discharged a few weeks later. Patient admitted in August for the same thing. He was discharged to home in October. Roughly 36 hours after that discharge, he was readmitted to the hospital with sepsis, and the patient went to the OR for the debridement. And the ethics note, or my note, at that admission was, daughter prefers discharge to home, but it has been demonstrated that this patient, that this should not be an option in view of the rapid admittance after the previous discharge. If the daughter refuses discharge to a facility, one might need to consider a court-appointed guardian to decide what is in the best interest of the patient. Social work note, safe discharge needed. Patient requires frequent care for the wounds. Patient needs to demonstrate that she can care for the wounds, able to change the wounds. And the plan was for the daughter to come in on the 8th and demonstrate that she could actually do the proper dressings, but after 10 minutes, she needed to leave the hospital. So what do we do now? What should be the discharge planning for this patient at this point? Obtain a court-appointed guardian, set up a safe discharge to the home, or not sure? Okay, give it a few more seconds. Okay, so let me end the poll. A significant majority thought a court-appointed guardian if the daughter continues to refuse placement in a subacute facility. So what happened? The patient was hospitalized for 41 days, and a safe discharge was scheduled for December 9th, and with all the home services and wound care supplies, transitional care consult was placed, and the patient would have 3 times a week home nursing. As an aside, there was physician documentation that the patient should be made DNR, DNI, and a pulse or MULS was signed. So this patient was discharged to home. And well, let me skip these slides here. So back to the June admission, he was previously hospitalized at Hopkins since December. He comes in severely cachectic, rigid folded extremities. Patient is severely critically ill due to extensive infected wounds. Patient is awake but not responsive. Soft tissue team saw the patient and determined that the patient was not an operable candidate. If the patient recovers and is able to be discharged, a guardianship should be pursued so that the patient could be discharged to a skilled nursing home. However, aggressive interventions such as CPR and dialysis appear to the healthcare team to be futile, and 2 attendings made this determination based on Maryland law. The daughter was informed of this determination. The daughter disagreed and requested to exercise her right for the patient to be transferred to another facility. However, 2 other hospitals declined transfer. Patient's hemodynamics continued to worsen and progressed to cardiopulmonary arrest, and the patient died. So my question is, well, one, how is this last case morally different from the previous 2 cases?
I don't want to be the one to dominate the discussion, but if nobody's answering, I will say it is different because patient doesn't have capacity to make the decisions. And the daughter showed consistently that she is not capable of providing care. It is not the question of patient's autonomy here. It is trying to accommodate the daughter's wish, which was tried and failed. So the thing here is any other alternative? Other daughter showed clearly that she cannot provide proper care to this patient.
Right. Yeah, go ahead.
I was going to say the same exact thing, that I think that in this case, the ethics committee they're making the decision without the input of the patient and in his best interest. And the daughter did not seem to have his best interest. She seemed to be in denial of what was really going on with her father.
Right. Yeah. Now, in speaking with the daughter, she said that his father said, "Never put me in a nursing home." So she was following that advice, but didn't realize fully the consequences. Between these cases, patient autonomy. In the first two cases, patient autonomy has a greater moral weight than familial autonomy, and meaning that we should be more likely to overrule familial autonomy as opposed to patient autonomy. So my question is, how do we explain the hesitancy to obtain a court-appointed guardian for this last patient compared with the inclination, quote unquote, to obtain a guardian for the first patient? I mean, I gave you the timeline for this patient. This patient got readmitted almost on a monthly basis. And I mean, this is all retrospective thinking for sure. But I'm just wondering about the delay, about recognizing that this was not a safe discharge. And in this case, I know Dr. Doty mentioned about patient escaping from nursing facilities, but obviously this patient wasn't going to do that. Again, this is retrospective thinking, and it's easy to use the spectroscope. But I find these cases interesting. All right. Any other final thoughts with these cases before we go on with the next case? Which is not about a safe discharge, by the way, or maybe it is. All right, well, let me make sure I give enough time for this last case, which was also very troubling on multiple occasions. The patient is a 58-year-old cachectic male with a past medical history of major depressive disorder, bipolar, multiple suicide attempts, including a gunshot wound to his face in 2020. He is now status both multiple facial surgeries and PEG dependent. On the current admission, the patient was emergency petitioned by his wife for a psychotic event, and he was admitted to the psych unit for depressed mode, hopelessness, inability to care for himself, and suicidal ideation. The patient had previously, throughout the last year, discontinued his 2 feeds and has said on multiple occasions throughout the year, he is done. So the question I like to ask, can a patient with a history of a major depressive disorder and quote unquote intolerable suffering have the capacity to refuse further medications? So what do you think? Let me show the poll. Could a patient with MDD ever have the capacity to refuse medications?
Does that include things like ECT?
Yes, good point. Any treatments. Okay, 2 more seconds. All right, let me share the results. Slight majority said yes, and then equally no for the other 2 results. So I think that's correct, that patients with major depressive disorder could demonstrate capacity to refuse. Now, somewhat similar question that's been making the rounds in Europe and in Canada: could patients with mental illness and intolerable suffering request assisted physician suicide, or otherwise known as medical aid in dying? And one article had the title, "Suffering is Not Enough. regarding assisted dying for people with mental illness. Essentially, one, in addition to intolerable suffering, one needs refractoriness of the suffering, meaning the
Right.
mental illness is treatment resistant, and the patient has to have the capacity to make decisions. So another point about this case was whether his mental illness was treatment resistant, and also whether he had the capacity to refuse further treatment. So on admission, further discussion with the patient's wife revealed over a week prior to the EP presentation, the patient suddenly stopped taking his medicines, stopped eating and drinking, and stopped sleeping. This occurred in the context that they had put down the dog two weeks previously, which is when he started not to want to go outside or do anything. This patient was very attached to this dog, and for the last few days, the patient has been restless and jumpy and unable to sit still. He told his wife he wanted to hurt her and hurt himself, and she started locking her door at the home. And that's why she did the emergency petition. Throughout the past year, the patient has lost significant weight due to stopping his 2 feet, and on presentation, he looked severely cachectic. More history. The patient actually decided DNI 1 year ago because he said, "I am done. I have had enough." He completed a MOLS form and signed it to confirm these wishes regarding his code status. Last year, for severe depression and suicidal ideation, he did undergo 9 rounds of ECT, and in combinations with medications did improve to the point of having a bright affect, expressing hopefulness and interest in pleasurable activities. However, ECT therapy would be short-lived, and there was recommendation for continued ECT therapy. However, the patient failed to keep these appointments, and the ECT treatments were stopped. He was also followed by outpatient psychiatry, and in discussing with his outpatient psychiatrist, he said that the patient had made little to no progress throughout the course of the year, primarily because he had been likely refusing medications for a longer period of time. So psychiatry here at the hospital brought up a good point. Yes, brought up a good point. When a patient was admitted to the hospital here, he had agreed to voluntary admission to psychiatry service with the prospect of ECT therapy and medication therapy. And hence, psychiatry was inclined to provide treatment because they said they had the consent of the patient. However, the patient developed aspiration pneumonia and transferred to the NICU, and hence psychiatric therapy was put on hold until the patient recovered. So a major issue in this case was about treatment-resistant depression. Is this patient's depression treatment-resistant in the sense he was refusing the medications, and however, he was responding to ECT treatment, although it was short-lived? So based on a superficial knowledge of the facts, I can't, for some reason, I can't launch this poll. What do you all think?
I have a comment. I'm one of the psychiatrists also.
Great.
With Dr. Doty. And in this particular case, he was not treatment resistant, because what we typically find, if someone has a positive response to ECT, we give them ECT again, they then improve. And then after they improve, then they're more likely to start taking the medications. following through with the regimen and diet. In his case, unfortunately, before we could even start, in this case, before treatment could even be started, he decompensated. And that is why there was no treatment, because he was on the unit. We were getting ready to get started with it. And
Oh,
he
you're talking about this admission.
Correct.
Right. Now, previously, he did respond to EC
Correct.
treatment, okay? And it would be short-lived, and hence the recommendations for follow-up. And
Well, right, because one of the things is that we did an acute course, and then sometimes if we recommend outpatient ECT for maintenance, sometimes it's difficult for family and individuals to comply and follow up with that schedule. So I don't know if that's the case. Dr. Doty can speak to that more.
Unfortunately, I took care of this patient more than one occasion. I was the doctor mostly administered ECT. I had an excellent relationship with this patient. Or chronically, things changed. Originally, when he used to come and get admitted, he says, no, I want to live. I want to get better. So he willingly went ECT, very successful treatment. He said, yes, ECT helped. Unfortunately, in Baltimore or around Baltimore, I think it is a problem chronically all over the country. Maintenance ECT is not user-friendly, especially we are not set up for maintenance ECT.
Right.
The only place that is set up won't accept, because it is a freestanding psychiatric hospital. They don't accept any medically compromised patients for ECT. We are the only one who can do it.
Right.
And this patient, as he deteriorated, he started sharing with me, he doesn't feel the quality of life is that much great for him. He cannot come for maintenance ECT. He also said he craves for tasting the food, which he cannot because he has to fed. So he clearly, and when he was completely conscious, he clearly expressed, he's saying, my quality of life deteriorated so much under the circumstances, I don't want to live anymore, which is entirely different. I treated several patients after going to court with involuntary ECT, but in those patients, actually court cross-examination, one of the questions they asked is, it is a retired social worker. This is another entirely different case. Who stopped eating and drinking after he became depressed, severely depressed, and he wouldn't answer any questions. I went to court. They said he has his advanced directives, which says he doesn't want CPR, he doesn't want tube feedings, whatever. My answer is, yes, if it is a terminal illness, but major depression is not a terminal illness. Major depression is a treatable medical condition. So court agreed with me. I gave ECT. Patient recovered well and thanked me for taking all the efforts. And he went home, lived independently. He was living for several months in a nursing home before he came here. So in general, there is more than what meets the eye. I'm familiar both legal requirements and also psychiatric and ethical requirements. And again, unfortunately, I don't want to say the name of the patient. In this particular case, we don't have, this is all over the country, proper facilities which can give maintenance ECT in a user-friendly way. Somebody to have maintenance ECT in our hospital is a big difficulty for the patients, and also we are not equipped.
Well, those are good points. And so essentially, I agree, the specific treatment itself of ECT had an effect, but it's
Correct.
like taking a drug. If the patient doesn't take the drug because of side effects, then the drug is not working. And in the context of this patient's social situation, for whatever reasons, he was not compliant with coming back. I know there was transportation issues as well. So in the overall scheme of things, and especially in the past year, he has lost significant weight due to stopping his PEG infusion. So overall, it just seems like, considering everything, he was not responding to the therapeutic regimen, if I could call it that. I agree. ECT was successful in the short time, but his overall picture, and again, we could put in his social situation as well, was interfering. So you brought up, let me end this case because I know we're over time, but you said, did he have a terminal illness? And in one sense, he doesn't have a terminal illness in terms of a identifiable somatic illness, but overall, he was going downhill, losing weight, and he was not adhering to even his medication. So in one sense, one could say that throughout the year, his depression was unresponsive to treatment and continuing without the feedings. One could say that maybe all things being equal, that he did have a terminal illness, taking in consideration the overall picture. Anyway, we could certainly talk more about that. I could guarantee it. Well, what happened was his medical condition continued to deteriorate, and we thought that, basically his medical condition was the determinant of his outcome. His wife elected for hospice care, and the plan was for hospice care. However, his medical condition continued to deteriorate, and 2 weeks later, he died in the hospital. A very difficult case regarding whether the patient actually wanted treatment. It appeared that he did, but his actions demonstrated otherwise throughout the year. A lot of multiple issues, and finally, we all agreed that, unfortunately, his medical condition was determinant of his outcome, and difficult case. Any final thoughts? I appreciate people staying to the end, but I did want to get that last case in, because I know we had some people from psychiatry who joined the call and added worthwhile thoughts.
Very quickly,
Yes.
I agree with the decision that was made. I would have done the same thing during his last admission. I didn't take care of him during his last admission. And there are more complicated situations which most of the people are not aware. His wife has a psychiatric illness, totally different type of psychiatric illness. I don't want to say it loud because there are a lot more complicating things. It is not what it looks like superficially. But I agree, finally, in this particular case, in this particular situation, knowing the patient longitudinally over several years, I agree with what was decided. That was his wish. When the quality of life deteriorated so much, he didn't want to live anymore. Before that, he wanted to live. He wanted to go back and live with his wife. We suggested alternatives. No, we agreed. His wish we have to respect, and he was keep on going back to his wife.
Right, yeah. One last question. There's a question on the chat, Dr. Doty. What about ketamine?
I have to take one hour to explain the whole ketamine thing. Ketamine is not...
No, I'm going to agree with you, Dr. Doty. Ketamine is not a good idea.
No, that is exactly what I'm going to say.
Right.
Ketamine is oranges and apples.
Right.
For somebody with serious depression, hospitalized, bedridden, ketamine is useless. And the recent study in New England Journal of Medicine is giving wrong impression. I wrote my letter, but unfortunately it was not published because the people who did and published the study were big shots in the country. And we know there is so much bias.
You're not a big shot, Dr. Doty.
No, I'm not. I don't consider myself as a big shot. But again, I can take 1 hour. I don't want to waste everybody's time. Ketamine has its own role for moderate depression, its own role for treatment-resistant moderate depression, but not severely depressed, hospitalized patient,
Right.
medically ill. It is not.
Yeah, that
Okay.
was he was too medically compromised for it. And then with all the monitoring that goes along with it, it's not going to be futile. It'll be futile to do so.
Well, early on, we did consider ketamine, but the hospital did not have the aerosol configuration. I was told that it was not available. Well,
I don't want to announce loudly. I'm in charge of starting the program with both esketamine and TMS, transcranial magnetic stimulation, as an outpatient procedure. I don't want to announce it beforehand because I want to have everything in place. But I had extensively studied both aspects, and that's why I said I can take 1 hour lecture or more than 1 hour lecture about both
Okay.
those issues.
all right, we'll give you that
Can I
opportunity.
just say one thing?
Yes.
Thank you so much for a very enlightening conversation. Wonderful and wonderfully difficult patients. The patients, in my mind, are lucky to have you and your staff and the discharging people to help them. It seems to me that you all did the best you could under the circumstances.
Well, Larry, I appreciate those comments. These are difficult cases, and that's why we know when we have an ethical dilemma. So again, thank you all for joining and contributing to the discussion, and I appreciate the messages in the chat, and I'll have a recording link for this ethics round, and let me wish everyone a good rest of the summer, and we'll see you again in the fall. Thank you again for joining.